Sepsis is a major problem worldwide, and it is associated with high morbidity and mortality rates. Sepsis can be considered as a bad infection, as a very severe infection with some form of organ dysfunction. That's what we call sepsis in our current language. Septic shock is, of course, the worst form of sepsis. Then there is acute circulatory failure with signs of altered organ perfusion, altered skin perfusion, altered mental status, decreased urine output because the kidneys are hypoperfused. And this is usually in the presence of hypotension. And at the same time, blood lactate levels are increased, typically above 2 milliequivalents per liter. So that is septic shock with mortality rates of about 40 to 50% around the world. Now, to treat sepsis, we need to keep in mind that there are three major components. One is the infection control, with antibiotics always, and sometimes the control of the source of infection. The second one is hemodynamic stabilization, always with some fluids and sometimes with vasopressors and perhaps high nootropic agents as well. And then comes the third component, which is more general, how to help the patient to respond better to the infection. So let's go over this. First of all, antibiotic therapy should be started early, within 1 hour in all cases, perhaps within minutes if it's really severe septic shock or meningococcemia or overwhelming postplenectomy infection. In the most severe cases, every minute counts. Now, we would like to obtain blood cultures before we start the antibiotic therapy, so that if they are positive, we can adjust the antibiotic therapy later. The issue is that the initial antibiotic coverage should be very large and cover for all possible microorganisms. And in many countries, like in India, that means really wide spectrum antibiotic therapy because we are dealing with multi-resistant organisms. And the initial doses should be relatively high to make sure that we hit hard. Again, later on, when we receive the data from the bacteriological laboratory, we may be able to de-escalate, to reduce the spectrum of the antibiotic therapy. The sepsis source control is important when there is a source to be drained. Of course, if it's a lung infection, probably not. But if it's an intra-abdominal infection, peritonitis, if there is an abscess somewhere, we need to drain the pus. We need to drain that abscess. And that should be done rapidly as well. We sometimes waste time waiting for the operating room to do the laparotomy, waiting for the surgeon to drain the abscess. So we must be careful and concerned about this. If we move now to the hemodynamic resuscitation, well, first of all, we need to give oxygen to all these patients routinely. And if there are some significant signs of respiratory distress, we should not hesitate to intubate the trachea and start mechanical ventilation, not only to improve gas exchange, but to decrease the work of breathing of these patients. It's important to do it early rather than late when there is respiratory and perhaps cardiac arrest. Now, fluid administration is always required because there are some fluid losses and there is vasodilation associated with the septic response with all these mediators. So we could perhaps start with 1 or 2 liters of crystalloids quite rapidly and evaluate the patient's response. With the Surviving Sepsis Campaign guidelines, we recommend first to continue fluid administration as long as the patient responds. If there is an increase in blood pressure, a reduction in heart rate, then we can continue. If there is no response, we need to stop. In the Surviving Sepsis Campaign guidelines, we say that we should give 2 liters in 3 hours, but 3 hours is very long. So that recommendation is really not very helpful. Now, the other thing is to correct hypotension, and we should not wait for too long before giving a vasopressor agent if hypotension is problematic. Noradrenaline, norepinephrine if you like, is the agent of choice today. So that's quite simple. Norepinephrine, what we used to call Levophed, that's the first agent for hypotension management. We should always avoid severe hypotension. It's always bad for the tissues. If shock persists, we need to insert an arterial catheter to have a reliable, continuous measurement of arterial pressure. If we feel that cardiac function is impaired, and that could explain a poor response to fluid administration, maybe adding a little bit of dobutamine may be helpful. Just a few micrograms per kilogram per minute. To follow that, if the patient is not improving quickly, if we have a central venous catheter in place, we could check the oxygen saturation of the venous blood in this catheter. And if it's rather low, it would be an argument to give more fluids, a little bit of dobutamine, and perhaps a blood transfusion. We also need to measure lactate levels from the beginning and make sure that over time they decrease. They do not go up over time. So this is repeated lactate measurements every hour. Every hour. Some people call it a lactate clearance. It's not really clearance. It is the evaluation of the cellular response to our treatment, making sure that it goes down and it does not go up when we measure it every hour.